This is lecture 19. In the last one, we talked about nociceptors and the mechanisms of nociception. In this one, we'll talk about injuries, not from the perspective of pain, but what happens in the tissues. How do we heal? And I'll go through 4 levels here, getting a little bit deeper each time, less superficial, more detailed. And then in the next lecture, we'll do level 5. So these are our topics, some basic vocabulary as it relates to injuries. Upon experiencing injury, pretty much the first thing you do is clot. So we'll talk about that. And then after clotting, the inflammatory phase happens. So we'll talk about that too, sort of superficially with that part, with inflammation. And the detail there we're going to get into in the next lecture. So let's start with level 1, the leaf rake. We're just scraping the surface with some definitions. And first up is indication. This is a reason, a valid reason to take a medication or do a test or perform a procedure or whatever. So like if you have congestive heart failure, a bunch of fluid builds up around your heart. So let's get rid of that fluid. Take a diuretic. That would be indicated, like a potassium sparing diuretic would be indicated in the treatment of congestive heart failure. Or like statins block cholesterol synthesis in the liver. So those are indicated in people with dyslipidemia. So indication just means a reason to do something. A contraindication is a reason not to take a medication or do a test or the procedure or whatever it is. So like massage would be contraindicated in burn patients who have like open blistering wounds. Like massage would be contraindicated. Statins would be contraindicated in patients who have horrible livers, so just a reason not to do something. Dislocation, that's a complete displacement of the joint surfaces. Subluxation is a partial displacement of joint surfaces that's followed by relocation. This can affect ligaments and cartilage and other tissues, leading to future instability, future laxity of that joint, though. Sprain versus strain. This is ligament versus muscle tendon. A strain, you're thinking muscle and tendon. Typically the myotendinous junction, typically the distal myotendinous junction, but that's a strain. Sprain is a ligament. And then macro trauma and micro trauma. Let's hold off on these for just a minute. I will come back to it. Before we get into the rest of the terms, I just a note that subluxation is again it's out and then back in. So look at it in 5 seconds and it looks exactly like it did before the injury, before the sublux, except you probably have some stretched out tissues. Now the bottom picture is that's supposed to be a chiropractor. It looks like a murderer, but uh, chiropractors talk about fixing subluxations. That's the famous thing they claim to fix, but those are already back in place by the time you schedule your appointment. Dislocations are a different matter. But one thing I wouldn't do if you go to a chiropractor, one thing I wouldn't do is that violent neck crack. There are lots of papers describing vertebral and carotid artery dissections, tearing of a, carotid artery, say, and you get an embolus, like a little clot ball that's thrown into circulation. And this is not a good place to have one. It's a really direct shot to the brain. If that's where the embolism docks, that's a stroke, and it's been observed on occasion in chiropractic care. Now, there are phases of injuries, how we classify these injuries. There's the acute phase. Let's call it like a work week. You get injured on Monday. Hopefully, you're out of the acute phase by Friday. This phase tends to be defined by inflammation, a topic we will continue talking about for the rest of this block. And then the subacute phase is like a week after that. Hopefully, you've gotten all the inflammation out or most of the inflammation out of the area by then, and you're beginning to rebuild the tissue in the subacute phase. And then chronic, this is the final stage of healing or stages, last for a while, um, maybe longer than a month, month and a half, something like that. If the injury, it just depends how bad it is. Now, people will talk about chronicity of injuries if they continue to last without improvement. And then there's acute on chronic. This is interesting and unfortunate territory here. Um, Predisposing an injury to re-injury, a limb or whatever to re-injury. It could be rewiring of recruitment patterns that sets the tissue up for re-injury, or maybe often the tissue wasn't fully healed. The integrity of the tissue is still weak despite having no pain, um, and appearing pretty functional, no issues with balance or anything like that. But if you leap back into activity too soon, the tissue won't be ready. But the tissues don't warn you of that. In the graph to the left, it's characterizing pain compared to healing. And there's a point where the pain signal, the purplish line on the left, falls below the pain threshold. At that point, the tissue is still really weak. It just means you got the inflammation out of the area. So you're not depolarizing nociceptors. That doesn't mean it's healed. It means you're currently rebuilding it. So pain levels decrease before tissue healing is complete, well before tissue healing is complete. So that can lead to the belief that return to play conditions arrive earlier than they actually do. And if something's a little bit damaged, it's way more fragile. Just watch people tear phone books. People do this professionally for some reason. This guy is like wearing knee pads and like Michael Jackson's bad suit. But if every page is a little bit torn in that phone book already, it's easy to finish off the tear. It's easy to rip the rest of the phone book in half if the rip is already started. If there's like a little centimeter tear in every page, you can finish off that rip. A fresh phone book, that's hard. You need like knee pads for that. And the same is true with your tissues. A healthy tissue is way harder to injure. So this is just another look at how injuries are classified. Again, acute, a bunch of inflammation. That's what's going on in the acute phase. Hopefully, the inflammatory period, this is maybe 72 hours, something like this. Get the inflammation in and out in 72 hours or so. Subacute, again, this is the following week. Just evict the inflammation and then get a bunch of fibroblasts in there to start blasting your fibros. And then there's the chronic phase. This lasts a while. Ideally, you can avoid acute on chronic injuries because that is when you really see the likelihood for lasting chronic pain. Substance P, CGRP, PKA signaling. These will lose regulation, and we can see pain overstaying its welcome and just squatting there in your leg or your hip or your back or shoulder, whatever's injured. Like once the tents are there, you can't get rid of them. It's just a permanent feature of the land. And in this case, the tents being pain, right? And the land being like your knee or your elbow or whatever. Acute on chronic injury is really increasing the likelihood that chronic pain will just linger and linger and linger each time you re-injure a tissue. Okay, so let's start digging into the crust a little more. We'll get our bow rake out. We're at level two. And so in our list of vocabulary earlier, I mentioned we would get into micro trauma and macro trauma. Uh, so the tissue, right, the Kleenex, that tissue, think of it like an incredibly dainty phone book. I mean, a Kleenex kind of tissue has some structural integrity if you apply stress. If you stretch it out a little bit, that tissue will hold. But if that Kleenexy tissue has a tiny tear in it and you stretch it, the whole thing just rips so easily. And our tissues do that too. So the graph on the left is a tendon. Stretch it out a little bit and you see micro trauma. But if you get to about 8% stretch, now you have macro trauma. It just fails. The tendon can't handle that, so it fails. But you're getting micro trauma before then, more and more and more micro trauma, the further and further that you are, the farther you're stretching it. Nothing catastrophic in the short term, micro trauma isn't, but accumulated micro trauma often does end in catastrophe. Um, so macro trauma, right? That's a big, overwhelming force that just takes out your tissues. And micro trauma is an accumulation of small insults. Micro trauma is mostly about anabolic catabolic signaling and so think about like the person at the checkout aisle at the grocery store scanning 3,000 cans every shift. It's just external rotation, external rotation, external rotation, external rotation over and over all shift long. The repetitive stress is the problem. One rep doesn't do anything. 10 reps doesn't do anything. But shift after shift over time, the repeated stresses will diminish messages of anabolism and catabolism signals predominate. And so the grocery clerk ends up damaging their rotator cuff by externally rotating a million soup cans in a year. And so that's just metabolic signals predominating. Micro trauma is very gradual. It takes time to accumulate those micro insults. And then again, macro trauma is not gradual. The single stress is more severe than the tissue can tolerate. And so like force vector and body position, this is what determines, which tissues are involved. So let's say a patient comes to you and they have a problem. And how do you tell what tissues are injured? I mean, if there wasn't trauma at the onset of the injury, it could be lots of things. I mean, who knows? This isn't really helpful information. I mean, it could just be anything. So this is obviously micro trauma for any mechanical problem. Like heart disease and diabetes and cancer. These aren't the kinds of micro traumatic insults we're talking about. So we're talking about mechanical stuff. Now, for the next slide, like avert your eyes if a sort of gruesome injury is off-putting. Go ahead and like just listen to what I'm saying. There's no reason to actually look at the slide. But macro trauma, that's what some of us are looking at here. And again, this is overwhelming force. It's more force than the tissue can tolerate in one blow. Now the questions, what's more likely to get injured, relaxed or tense tissues? Tense tissues. Relaxed tissues fare better. Tense tissues are more likely to endure the damage. And then in macro trauma, is it isolated tissue or multiple tissues we see being injured? It's generally multiple tissues. It's probably bone, ligament, and muscle, tendon units. And depending on the direction of the force and the application of it, where it's applied, you can usually figure out what the injury is. Um, again, the only problem is it's not usually one thing. If there's enough of an impact to blow through one tissue, you've probably, blown through two or three. Well, the bone is broken, but all the tissues around the bone, the muscles and tendons and ligaments, those are all fine. Not likely. That's not likely. And again, the directionality and the magnitude of the force really determine which tissues get injured and how many tissues are involved. Okay, so we're now in level 3 of 4. We're tilling the soil now. So you begin with an injury. Who cares what it is, right? You injure yourself somehow. You stub your toe. You get, punched in the stomach. You stabbed by a pencil. It shows there. You're like this red sunburned guy bleeding out of your scalp and you slip in a puddle of your own blood. Right now you're injured. You've injured a tissue of some sort and you have local damage. And then from here, everything that happens, regardless of what caused the injury, is pretty much the same. It's really similar, even if it was just some good sets of lunges. The course of healing, the course of damage and repair and remodeling is really, really, really similar. Um, so it doesn't matter where the injury is, what tissue is involved. You're going to have some blood vessels and lymphatic vessels near the site of injury, and they're going to be damaged too. You're punctured by a pencil, you twist your ankle, you overdo the Alfredson protocol, right? You have bleeding, blood and lymph both. Your lymphatic circulation is all over the place. It's just a interwoven mesh of capillaries, which is why both blood and lymph, those vessels from both of them get disrupted. And of course, everyone knows what blood is, but lymph is it's a bunch of interstitial fluid. It's clear, watery stuff bathing the cells. And it collects in lymphatic vessels. Eventually, it dumps into the subclavian veins, subclavicle, you know where that is. And that's where it gets mixed with the actual blood flow. It's not intracellular fluid. Lymph isn't. The fluid inside of your cells, in the cytosol. Lymph isn't that. It's extracellular fluid, but it's not in your blood. The interstitial watery stuff bathing your cells that gets picked up into lymphatic vessels, that's your lymph. And like with blood, there's a bunch of stuff in it. It's not just water. And that stuff starts leaking out of your blood, leaking out of your lymph. And if you're a bleeder, right, it's gonna keep leaking. Um, so that's potentially bad, right? You have to stop it. And so you do two things. One of them is vasoconstriction. Like if your toilet is overflowing and emptying onto the bathroom floor, you can constrict the flow of water. There's a shutoff valve on every toilet. And you do something similar with your vasculature. You constrict it so that just less blood is going to those leaky spots. And then you also form a clot to plug up that wound, unless you had hemophilia or von Willebrand disease. I'll talk about von Willebrand soon, but if you have one of these, you just keep leaking. And when you look at the royal family, we see a family tree here. That's the lineage of hemophilia, right? The royal disease. It passed it to royal families of Spain and Germany and Russia. One of the Spanish people died after like ran into a telephone booth. There's a car wreck, like the tiniest car wreck, and died. So if you can't clot, you're in trouble. Just like your bathroom would be in trouble if you couldn't fully shut off the water. It would just slowly leak until it floods the world. So you have to build a clot. And what a clot is, externally on the outside, it's a scab, right? Like these knuckles, like this 6-year-old kid. Now, within the tissue, inside, the internal clot is a provisional matrix. It's made out of fibrin and fibronectin. Fibrin is fibrous. It's a fibrous protein involved in blood clots. And then fibronectin is a glycoprotein. It just, binds to stuff. So we have glycoproteins and proteoglycans. A proteoglycan is a protein and glycan, a carb together. It's protein with a carb. A glycoprotein is carb with a protein. They're both carbs and proteins combined. The difference is that a proteoglycan is very carbohydrate dense, and a glycoprotein is more like proteinaceous, right? Whatever word is closing, just like the headliner of a concert, the last band to play or the last artist to play is the biggest name. Same thing here. A proteoglycan, there's more carbs. A glycoprotein, there's more protein. Um, so that's really what a clot is, though. It's fibrin and fibronectin cross-linking. And then platelets adhere to it and help initiate the immune system's response. So once the site is stable, once your toilet is no longer overflowing, you'll vasodilate, allow the full flow of your blood back into the area. And this is when you see and feel, very much feel, clinical presentations of the injury. And the pain, the redness, the swelling, it might feel hot. And then usually there's also a loss of function. There's some dysfunction, some extent of dysfunction, depending on the injury. So all right, so what explains these things? The redness, that's blood flow, right? There's a ton of blood in there. It's red, right? So that's why things are more red when they're injured. Pain, that's prostaglandins, it's bradykinins, it's chemicals, what we've been talking about lately. It's chemicals lighting up the nociceptors. And you know how nociceptors work. This is inflammatory mediated nociception, maybe some mechanical depolarization too, but mostly chemical nociception. Heat, what's making that big swollen finger hot is metabolism, right? Repair is expensive. I mean, like burn victims, they have to eat a lot. Uh, if burn victims aren't eating like they're going through puberty, they'll get severe muscle wasting. Anytime metabolism, and there's a lot that goes into that, but anytime metabolism is elevated, the tissues are going to be hot. That's why you sweat so much when you exercise, at least intensely. If you're exercising intensely, you sweat a bunch, you get hot. It's the same thing for healing. That's a hot metabolic activity. And then the swelling, we'll talk more about this soon, but the inflammatory environment, what's depolarizing the nerves, all that, it doesn't just inflammation doesn't just make your nociceptors hurt. It also makes vasculature leaky. Proteins will leak out, and then fluid follows. Your blood is half water, and that just leaks out of the vasculature following, proteins and cells that head out too. We'll talk more about that. But once the site is clean, after the inflammatory phase, the next step is to rebuild the tissue. But you don't just start building the final edifice of your tissue. You begin with basically scaffolding. The first kind of collagen you deposit is collagen 3, which looks cobwebby. It looks like spaghetti. It's not sturdy. But then over time, you replace that with collagen 1, which is just these nice, thick, strong beams of collagen. And if all goes right, you're healed, right? But lots of things can go wrong. Mostly, what's at risk of going wrong is the mechanical loads. Too much loading will break all the tissue all over again, and it's going to be a while before you have really nice collagen 1 in there. And so, how much force that tissue can endure very gradually increases. When the pain is gone, when pain goes away, the ceiling is still low. That break point is still really low. But opposite of that, the application of too much force, right? You can also apply too little force and compromise healing that way. You need some mechanical loading to signal the adaptation. And we'll talk about that in the next block. But for now, just know that you need a little bit of mechanical loading, which increases throughout the healing process to help trigger the remodeling. So that ends level 3, the long-handled cultivator. And we've gotten through all the topsoil of healing. And that topsoil summary being you get injured. Maybe you're kicked in the shin or you're hit by a pitch, right? You work out really hard, whatever, you bleed a little, no matter what it is, you bleed a little. Maybe you bleed externally, it depends on the injury, but you definitely bleed internally. And it's coming out of your blood and your lymph, but you can't just bleed forever. You die. So you have to stop all that leaking. So you vasoconstrict to limit the amount of spillover, and you form a clot. And now you've fixed the leak. So you can restore blood flow, you can vasodilate, restore blood flow, and then clean up all that mess, do the custodial work. So you get an inflammatory response. That's the custodial work. And then once it's all clean, you can start healing. You can repair the damage. And at first, you just lay down scaffolding, right? You get ready to sort of fix the building. And then eventually, you correct the actual structure itself. You piece together the final edifice. And when you're all done repairing, hopefully, you're healed. If all goes right, you've wound up with a functional tissue. If all goes wrong, you've wound up with dysfunctional tissue, and that happens commonly too. So now let's start the real excavation. Level 4 with back posture that minimizes lumbar compression. So we'll start digging a little bit deeper, but we begin at the same place. You get injured. It doesn't matter what it is. It doesn't matter what the tissue you injure is. You're gonna have blood vessels and lymphatic vessels that are near the injury site, and they're going to be damaged too. Those vessels will be. So you'll start leaking. So we vasoconstrict, right? Limit the amount of blood flow going to the site of disruption, and we clot to plug up the holes. And we'll talk more about fibrin, fibronectin in like literally seconds, where they come from and how they link up, the steps of a clot. But first, sort of roughly, this is what it looks like. And when you get a clot, you see this net of cross-linked fibrin and fibronectin, and then you see a bunch of blood cells in there, red cells and platelets. You see both of them. Okay, so here's how it works. Um, the ones that are highlighted in red here, prothrombin, fibronectin, and fibrinogen. These are in your blood, they're in your lymph, they're just in circulation. They're circulating there, kind of like police on patrol with nothing to do. But then something happens. There's damage, so they flow out of circulation. They extravasate, just means leave circulation. The prothrombin gets converted into thrombin through two enzymes, prothrombinase and thromboplastin. You see calcium in the diagram too on the right side of the diagram. Because the assembly of the prothrombinase enzyme, that complex, is calcium dependent. A bunch of proteins are bound together with calcium. This is linked to that. That thing's linked to that other thing, using calcium. But you don't need to know that. Ignore the calcium stuff. It just happens to be there. So I'm explaining. But so we have a couple of enzymes, right? Convert prothrombin into thrombin. Thrombin itself is an enzyme, and that enzyme thrombin converts fibrinogen into fibrin when in the presence of fibronectin, and then that fibrin and fibronectin cross-link. That's your clot. And if these diagrams help, these are students made these in the past for a past class, and I thought they were good. I thought they did a good job on them. And so if these diagrams give you a clearer understanding of the clotting cascade, then pause here, but I'll just keep moving on. So you can see what the clot looks like here. You have a broken vessel wall, red blood cells and platelets are leaking out. And there will also be a bunch of proteins in the blood and in the lymph, and yeah, this is your fibrinogen and fibronectin and prothrombin. Those things are among them, and all this stuff is leaking out, and so you'll get some vasoconstriction during this time, and then the clot happens. And this is just another look at the same thing. In circulation, you already have all the ingredients for a clot. So you get a big hemorrhage. Again, the word extravasated means the thing is coming out of the blood and into the extracellular space. So fibronectin is one of the extravasated things. And you make a chain link fence out of fibrin and fibronectin. And all of that linking provides a provisional mechanical stabilization of the wound. And then some platelets come in and adhere to the extracellular matrix, and they start secreting their stuff into the great wide open. And that's how chemotactic signaling begins. Let's summon the immune response, chemotactic signaling. And some macrophages are already in the area. I mean, they start waving their flag too. The major role of macrophages doesn't come until later. We'll get to that in the next lecture. But early on in the healing process, some macrophages will just be there, again, like patrolling cops, and they'll contribute to the chemotactic signaling. But the platelets are the real first responders, the ones that do most of the chemotaxis, the chemical summoning. Some of the platelets are already in the area, but a lot of them arrive, and they're the first incoming responders to the damage. And among their roles, they contribute more thrombin, which converts more fibrinogen into fibrin. Now, at some point, you have to like break stuff down. You have to break down fibrin clots. That's fibrinolysis, fibrinolysis. Plasmin is the primary enzyme that does it. It's a protease. And so like a protease, an ACE, ASE, that breaks down a protein, right? And so fibrin is a fibrous protein. So you don't need to know that, but just realize that at some point, you have to break this stuff down. And you have some ACEs, you have some enzymes that do that. So earlier I talked about the royal family and hemophilia. That's different from von Willebrand disease. Von Willebrand factor is a protein. It's a blood glycoprotein that binds to other proteins, and platelets are among the proteins it binds to. That's how platelets adhere to a wound site. If you have a deficiency of von Willebrand factor, or you have dysfunction, that's von Willebrand disease, and you'll probably have like a really bleedy constitution. Internally, that means gastrointestinal bleeding. Externally, it's a bunch of nosebleeds. So that's von Willebrand factor. And once the platelets adhere to the exposed, extracellular matrix through von Willebrand factor, they get activated. Um, so here in the picture, what we're looking at, that's a red blood cell. It's an activated platelet. That's the yellow one, is activated platelet. And then there's the neutrophil, the blue one, the white blood cell that we'll talk about in the next lecture. The platelets, these come from granulocytes. They contain these little vesicles full of stuff that can be secreted, growth factors and cytokines. And so they secrete additional stuff. Platelets show up in a hurry and secrete stuff. That's what they do. Wherever they're bound, that becomes a hub for chemotactic signaling. And again, wherever the injury happens, there will be macrophages already there, the resident macrophages. In addition to the platelets, these ones are sending out chemotactic signals. That's how a lot of these migrating cells will get into the area. Now, stuff moves through the body by different means. We've talked about ions moving in like an action potential, sodium and potassium, things like this. That's concentration gradients. Gases move through pressure gradients. If you pop a balloon, the air doesn't just sit there all crammed, tightly together. It rapidly moves into lower pressure spaces. But chemotaxis is another way of movement of things in the body. It's chemical gradients. You have attractants and repellents. You have directors directing the traffic, the chemical traffic, telling it where to go. So that's chemotaxis. Now, all this chemotaxis, once you get it underway, the vasculature gets porous. It becomes permeable. It gets leaky, not damaged leaky. It's just porous enough for the cells and proteins to get out of the blood and into the surrounding tissue, because the injury, it will have damaged the vasculature, but it damaged other stuff too. And that stuff isn't in the blood flow. Your muscle and whatever isn't inside of your blood vessels. And so if that inflammation is so the it's immune cells and inflammatory chemicals and stuff, if that's stuck in your blood, that doesn't help clean the surrounding tissues. And that needs to be cleaned and fixed. So lots of things, histamine and serotonin and bradykinin, lots of things are going to contribute to vasodilation and leaky blood vessels. Earlier, we talked about redness and pain and heat and leakiness. Remember, redness is blood, heat is metabolism, pain is mostly the inflammation depolarizing the nociceptors. But that leakiness in the vasculature, that's what's getting all these cells and proteins out of the blood and into the surrounding tissues. And that's why you're depolarizing the nerves, is you're getting all that inflammation around them. And so they're all doing the cleaning, and eventually you have to do the repairing out there. But where those proteins go leaking out of the blood and into the tissue, water follows. Water follows those proteins. Um, and you know that nociceptor activation, depolarization can impair muscle action. Afferents affect efferents, but that swelling that follows the inflammation, that can make a mess of function too. So if you take someone's knee and just inject a few cc's of saline into it, you'll see a loss of function. Um, so you know how to explain the swelling, you know how to explain heat and pain and redness, and you know how to explain the dysfunction. Here's our summary of everything we have so far, right? You're injured, the vessels break, you leak, you vasoconstrict and clot. You have platelets and macrophages initiate, especially platelets, initiating this pro-inflammatory response, chemotaxis, vasodilate. The vasculature becomes leaky, not injured again, but just porous. Um, and then those proteins and cells get out into the surrounding tissues. You're depolarizing nociceptors, water follows, and that's your swelling. So, wrapping things up, um, here are the review questions for this lecture. And I will see you in the next one where we do level 5 of healing. So we'll dig a little bit deeper.